not only a speaker, he is the best surgeon, best orthopedic, minimally invasive surgeon in Peshawar. And he has a lot of degrees that you can see on the website on our first lecture. And I am very thankful to Professor Salma Kundi. I would like Dr. Salma Kundi for the introduction of Dr. Shabir Awan Sahab.
Assalamu alaikum. Dr. Shabir is a very, very fine orthopedic surgeon, but he's a minimally invasive surgeon. He has specialization from the American board in minimal invasive surgery and from Canada as well, and then fellowship in laser spinal surgery. He worked as an orthopedic surgeon in Muhammad Medical College, but nowadays he's practicing privately and is an asset for KPK. Now I give it over to Dr. Shabir. The topic is backache pain and how to overcome it.
Yes, before we start today's session, I will request all the participants to mute their mics so we can listen Professor Shabir Saab smoothly, and you can ask the question at the end. And if anybody want to ask the question, raise the hand. I would like that you should avoid to ask any questions during the session. And if you want to write something on the inbox, you can also message me so that at the end we can facilitate you for the communication of Professor Shabir Awan Saab. Over to you, Professor Shabir Awan Saab.
Bismillahirrahmanirrahim. As it's my first lecture on the PMA forum, so I would like to briefly introduce myself. I am from Peshawar, and which is known as City of Flowers. I did my MBBS from Khyber Medical College, Peshawar, and after doing MBBS, I went to UK and do my FRCS from Royal College of Glasgow. After that, I was selected as a candidate for the minimally invasive spinal surgery American board among the 54 surgeons. So I did my diploma at American board in minimally invasive spinal surgery from USA. Then I did my fellowship in laser spinal surgery from United Kingdom. And as orthopedic basically is engineering and it's all mechanics, so I did the orthopedic engineering also from University of Wales. Then I was selected for the AO Spine Fellowship from Canada, Ontario, which I did with Dr. Bailey in Ontario, Canada. I have also written a book, The Pearls of Orthopedic Training, which is read all over the world and mostly in UK and America and India. And it's basically ethics about the doctor, that how you become a good doctor. There is not much clinical stuff in that book, but it is tips how to become a good doctor. I'm also a chief editor of the Ortho Bulletin, which is quarterly magazine for the orthopedic community. Now, my today topic is management of the back pain and sciatica. Back pain and sciatica topic is so long that if we can speak hours and hours, days and days, it will not end. But I will try to accumulate all these maximum and possible important stuff in just this lecture. Basically, you must have heard that we give the example of the back, any strength or any power or any importance, we say the backbone. We give the example of the backbone. और अल्लाह ताला ने कुरान में इंजीर, जैतून, कोहेतूर और शहर मक्का की कसम खाकर फरमाया लक़द खलक़नल इंसाना फ़ी अहसन तक़वीम, यकीनन हमने इंसान को बेहतरीन सूरत में पैदा किया. और इस बेहतरीन सूरत या बेहतरीन ढांचे का जो महवर है, जो मरकजी सतून है, वो हमारी कमर या रीढ़ की हड्डी है. इसी तरह एक हदीस का मफहूम है कि इब्ने आदम के बदन की हर चीज को जमीन बोसीदा कर डालेगी सिवाय पूंछ यानी दुमची या जिसे हम कॉक्सिक्स भी कहते हैं इसी से इंसान को बनाया गया और इसी से इंसान को दोबारा उठाया जाएगा। इसी तरह एक और हदीस कुदसी है जिसका मफहूम है कि हमने तुम्हारी कमर को ताकत अता की और इसे मजबूत किया। ये तो बातें थी सारी कुरान, हदीस कुदसी और हदीस की। शोहरा ने भी इसे जो है अपना मौज़ू सुखन बनाया और कमर जलालवी तो यहाँ तक कहने पे मजबूर हुए कि पीरी से खम नहीं कमर में है कमर, मैं झुक के ढूंढता हूँ जवानी किधर गई। बेसिकली दिस डिजेनरेटिव डिसऑर्डर, लेकिन वो ये मानने के लिए तैयार नहीं थे। आज के टॉपिक जो डिस्कस हम करेंगे उसमें इंट्रोडक्शन एंड हिस्ट्री ऑफ द बैक पेन, causes and types of the back pain, understanding through the literature, available ways of treatment, and then take home message. ये lengthy topic है लेकिन मैंने इसको short किया है. So get ready and be on your toes. Low back pain. It is as common as flu in winter. It is second only to the headache as far as pain is concerned. And it is second only to the respiratory tract infection as a cause of visit to the doctor. It is as painful as piles and sometimes as crippling as stroke. 4 out of 5 adults experience it in lifetime. Can occur for no apparent reason, and surgery is not always needed. That would be my main essence of this lecture, that surgery is not needed always. It is needed, but in less than 5% of the cases. If you go back the historic review of the back pain, history goes back to the history of the mankind, and the people living in the Stone Age used to have the same pain. If you look at this screen, 50,000 years ago, if there was a back pain, they used to take the swana bath, which is similar to the hot water bottle or heating pad as we use here in our houses or in the physiotherapy department. Then acupuncture in the new Stone Age, which is still practiced in Islamabad and other countries, it is still under practice. Then inversion therapy, which is 400 BC, they used to hang the patient upside down, and the philosophy behind this treatment was that the intervertebral disc space get increased and the pressure on the nerve which is coming out from the intervertebral foramina is reduced and relieving the pain. Then back pain therapy in the 16th century, this cruel method, from the picture it looks, but it was also in practice. And this we must have seen in the villages, our villages, that the patient who has a back pain, they ask the child to walk on the back. So this is basically originated from the 16th century. Bloodletting, that's khun nikalna. This is still practiced in Peshawar also and in other cities. And I remember that one patient, educated couple, came to my clinic and there was a dressing on the foot. And I asked, what is this? So the husband said that she is ye padi likhi jail hai. She has a belief in the bloodletting. So I took her there and did the bloodletting. But I don't have any belief, so I came to you. So I said, you did wrong, because you should have come after 2-3 weeks after this bloodletting. Because if for example, with my treatment, she get better, so you will both will fight that either the cure was from the bloodletting or from my treatment. So it's still in practice. Chiropractic in 19th century, and then came the osteopathy in 1892. And cupping for the back pain, जिसे हम हिजामा भी कहते हैं, this is still practiced in many cities of the Pakistan. Baba Mardan, that is one person in Mardan that who put a hot iron and he burned the skin, as you can see here. This is the burn, and then he put a charcoal on it, and do the dressing and ask the patient that your pain is gone. And definitely when you have severe pain in this area, you will forget about the back pain as a back pain theory. Yet another Pane Baba, in Pashto say Pane Baba, it is known as Pata Baba, which is he used to put the leaf on the foot and do the dressing, and it irritates, inflamed, and then get it infected, and then pus comes out of it, and he tells the patient that pus will come out, dirty fluid will come out, so do not afraid, because that all the dirt and all the pus in your leg, and it will come out and you will get better. Then surgery, laminectomy, that a big hole you can see that this is and it is basically, if you have hammer in the hand, then everything is a nail for you. So you have seen that so many ways of treatment, which means that nobody knows the exact cause of the back pain, and whoever find the cause, they start treating that thing. So it is basically still, we don't know where the pain is coming from, as our spine have a lot of structures and pain can come from anywhere. But if you suspect the disc only, I'll come later on when we review the literature, that if you suspect the disc only, so you will do the discectomy only, which is not a proper way. Causes of the back pain. Let's discuss what are the causes of the back pain. And mostly 90% of the causes of the back pain are the patient related, not a surgeon related. For over 100 and different causes, doctors rarely be able to make a diagnosis and call it non-specific low back pain, which means they have not understood the cause of the pain, that where the pain is coming from. Either it's coming from the muscle, it's coming from the nerve, it's coming from the bones, it's coming from the dura, it's coming from the nerve, from where. So they label it as low, non-specific low back pain. Most of the causes are due to the lifestyle. And I always tell the patient that sciatica and back pain is not a disease, it's a lifestyle disorder, which need to be addressed and which need to be corrected, and the pain will go away. It really needs doctor's help. You will see later on in my presentation that most of the causes are the patient related, so they should address it. For example, starting from this long list, I have included only few, and lack of exercise, then sedentary lifestyle, then overweight. Because if we are 1 kg overweight, the pressure on the L5S1 is 10 kg, 16 hours a day. 16 hours a day mean that when we are sitting, standing, and running, while 8 hours we are just lying. So 16 hours a day, 10 kg for 1 kg overweight. So you can imagine 10-15 kg overweight is a normal thing in our society. So you can see that if we are having 100 or 150 kg strain or stress or force on our L5S1, then you can imagine that how that disc would be. Next one is poor posture. You can see here that it's a normal posture, then it's a forward head, then thoracic kyphosis, lumbar lordosis, sway back. These are all the postures which results in the back pain. Normally, it should be straight like this, and plumb line. Plumb line mean when you put a line starting from the ear, it goes down to the ankle joint. So the over posture is one of the main cause of the back pain. If you see this gentleman, how he's sitting, if this gentleman, so they definitely they will get a back pain. Then pregnancy is a well-known cause of the back pain. Coming to the furniture, there is a strange thing, Mulazam, that there are only two things which covers our whole life: our shoes and our bed. In bed, we are 8 hours, and on our shoes, we are 16 hours. And these two things, two items or two objects are the least bothered for us. We go for the design. If there is a good design of the shoes, we take it. We don't see that it's comfortable or not. Similarly with our bed. So definitely spine will cry. Then lifting. There is a wrong way of lifting which injure the ligaments and muscles of the back, and strain will result in the pain. Then smoking is also a well-known cause of the back pain. And in America, some surgeons do not operate on the spine if there is a history of smoking. So they've asked the patient first to quit the smoking and then come back after a couple of months or maybe 6 months. Then we'll do a surgery. Otherwise, you can go to any surgeon who can do the surgery. But I will not do the surgery because the results of the surgery will not be good if you are a smoker. Then depression is the well-known cause of the back pain. It's a lengthy list. And footwear, as I said before, that we go for the fashion, we don't go for the proper as a heel. Heel is, you can see the heel here. Normally, 1.5 inch heel is acceptable. If more than that, that will put a stress on the L5S1 and result in the pain. Workplace is another reason of the back pain. So, do we doctors have any role in addressing these causes? The answer is big no, because it needs the patient's attention and willingness to address the causes. Now let's come to the causes which we can treat are the medical causes in the spine. For example, injury that can be due to the disc, vertebra, ligaments, or joints. So we can treat that. Similarly, deformity that is congenital or post-traumatic, and disease like a cancer, HIV, TB, other diseases. Degeneration, that is spondylosis. So these are the causes which we can address and which we can help the patient. Prolonged use of the medicine like the steroids, and gynecological and urological diseases. So if you compare, the 90% causes are from the lifestyle, while the 10% causes are from the medical related or the doctors related issues that we can address. Let's come to the diagnostic triage. What types of the back pain we can have? There are 4 types. Patient comes with these 4 types of the back pain to us. Number 1 is a simple back pain or lumbago. Second is nerve root pain, or we call it sciatica. Third is the serious spinal pathology. And fourth is the spinal emergency or cauda equina syndrome. So these are the 4 types which we can choose. And fortunately, the 95% patients are from this type 1, back pain or lumbago. Less than 5% are in the second category, like sciatica, and less than 1% is in these 2, spina, cauda equina syndrome, and the serious spinal pathology. Simple back pain. It is axial pain, which is musculogenic or muscular pain and mechanical in nature. And it varies with the physical activities. And it affects the lumbosacral, buttock, and thigh only. It don't go below the knee. And the common age group is between 20 and 55. In this age group, the back pain is mainly simple back pain, which is mechanical in nature. And patient is well. They don't have any other symptoms like a fever or any other symptoms. And prognosis is very good. It's 90% of the acute attacks settle within 6 weeks. And 60% of the patient has recurrence in the next 1 year. And recurrent attacks do settle in 3 to 5 years. So these recurrent attacks are also, as I mentioned before, due to our lifestyle. If our lifestyle is better, even these recurrent attacks will not come. Mechanism is a muscle strain and disc degeneration. So this simple back pain is the result of the muscle strain and disc degeneration. So you can imagine that if we receive these patients, so 95% have no neurological deficit, no neurological involvement, so we can treat it conservatively and with other methods of the lifestyle. Second, specialist referral is not required. If there is any general practitioner listening to this talk, so they should not refer this patient to the specialist, they should treat themselves. Second is the nerve root pain or sciatica. That is also called as a neurogenic pain or unilateral. It is unilateral leg pain and usually dermatomal. Peripheral or neurogenic radicular pain, as I said before, you may have the pins and needles and numbness in the same direction of the nerve which is compressed or which is irritated. There is a difference between compression and irritation. I will come later on. And radiates to the buttock, posterior thigh or foot. In first pain, simple back pain, that pain doesn't go below the knee, whereas in this case, the pain goes down to the foot. And less than, as I said before, that less than 5% of the patient comes in this category. And prognosis is reasonable if no severe deficit. 50% recover in 6 weeks. As in a simple back pain, 95% patient recover in 6 weeks, where in this case, 50% patient recover in 6 weeks. And recovery rate is slower than simple back pain, as I said. Specialist referral if not settled in 6 weeks. So if you are treating this patient and it's not settling, then you should refer this to the specialist that he should do some investigation that why this pain is not subsiding. As I said before, specialist referral not required unless signs of the severe or progressive weakness in the lower limb or reduction, red signs. Number three, third type is serious spinal pathology. That if below the age of 20 and above the age of 55, if you have back pain patients, so you should not take it lightly, because below the age of 20, there is no mechanical back pain, but there are other causes, like maybe starting scoliosis, maybe Sherman disease, maybe the spondylolysis, which is sometimes congenital, sometimes acquired. It's a breakage of it's a fracture due to spondylolysis. And above the age of 55, there may be carcinoma or tuberculosis or osteoporotic fracture or whatever. So in this group, if below 20 and above 55, if you receive the patient, do not take it lightly. Investigate and find the cause. And it's non-mechanical pain, meaning pain is present all the time. And mostly it is thoracic pain. In the past history of the carcinoma or steroids or HIV, you can explore in the history taking. And patient will be unwell or maybe giving the history of the weight loss. And maybe the structural deformity, as in case of the TB, a spine, or any osteoporotic fracture. But fortunately, this group is less than 5% of the patients comes in this group. Red flags. What are the red flags? If there is an infection and fever with a back pain, IV drug users, HIV, tumor or history of the cancer, history of the steroid use, and trauma such as fall or accident, and Cordova-Equina syndrome, in which the bowel and bladder symptoms will appear. Specialist refer is mandatory and recommended. The tests are needed to make the diagnosis, and the specialist will treat the cause, if it is cancer, or if it is osteoporotic fracture, or whatever it is. And before sending to the specialist, you advise the rest for a couple of days or until he has seen the specialist and do the investigation to rule out any cause. Number four, the fourth type is spinal emergency. It is Cordova-Equina syndrome, in which the bladder dysfunction, bilateral leg pain, lower extremity weakness, saddle anesthesia, poor anal tone, and maybe foot drop. if you see these signs, this is an emergency. You can't wait for, or you can't rely on the conservative treatment. You send the patient immediately to the nearest emergency or nearest orthopedic or spinal surgeon. And this cardiac equivalence syndrome can be due to the huge prolapse disc. Normal prolapse disc may not cause this, but if there's a huge disc which put the pressure on the spinal cord and may result in the cardiac equivalence syndrome. Second is fracture, and third is cord compression tumor. So these are the three causes of the cardiac equivalence syndrome. Cardiac equivalence syndrome is an emergency, and it is specialist consultation, immediate and urgent. Even in the middle of the night, you ask them to go to the hospital that they start treatment. It requires urgent surgical decompression. Is a primary absolute indication. It's an absolute indication for the acute surgical decompression of the lumbar disc herniation. Investigation to manage. So what are the investigation we offer to the patient coming with a back pain or sciatica? The first one is the X-rays. X-rays not on the first day, but if the patient history is more than one month or 6 weeks, so you can go for the X-ray. But here in our practice, we do the X-ray on straight away because patient comes to us with a history of couple of months and some maybe years. So we do the X-ray first and then see if there is any information. MRI basically it's highly sensitive and specific, but unfortunately there are high rates of abnormal findings on MRI in normal people, and you will be astonished to see the in the literature that see this slide now, that in the cervical spine 5 to 35% of disc herniation and bulge in the asymptomatic patient. It is an asymptomatic patient and did the MRI of the cervical spine or lumbar spine. And in the lumbar spine, if you see 68 to 96% of the disc degeneration and 50 to 84% of disc bulge. So here comes a point that when the patient is complaining of the back pain and saying the pain is going down the leg and there is a disc bulge. So we surgeon, we advise them for the surgery, which is not the proper way. I'll come later on in the presentation that what are the ways to treat this patient, but this is very alarming that MRI show the false positive in the asymptomatic patients over the age of 40. False positive. These are the literature full of studies saying about the fracture. Now look at this slide. If you see the imaging findings, the disc degeneration, signal loss, height loss, disc bulge, protrusion, annular fissure, facet degeneration, spondylolisthesis. So these ranges from 3% to 96%, but rather 37% to 93%. So you can imagine that, but it's unfortunate because sometimes the patient comes and they himself ask that what I actually these are the names known in the community that MRI. Sometimes the patient bring the MRI with him, and I say, who advised you? So he said, Dr. Sahab, aapne karni thi, to isliye humne khud kar li. So this need to be spread, virally spread, that we should not go for the MRI because MRI is not a diagnostic investigation. Please listen to this, that MRI is not diagnostic investigation for the back pain or sciatica. It is a planning investigation. When we decide that we are going to operate this patient, then to plan that which level we are going, which side we are going, then we do the MRI. Review of the literature and the new strategy of sciatica. If you look back previous 100 years in the last century, the first 50 years there are so many different causes and etiology existed, as we have seen in my previous slides, that there are so many causes. And but in the second 50 years, second half of the century, this degeneration took over almost entire the literature about the low back pain because of this MRI, as the tendency to prefer the organic and physical abnormalities as etiology. If we see disc protrusion, we suspect the cause. If we see degeneration, we suspect the cause. If we see extrusion, we consider it as a cause. But the clinical skills are going down and down. We don't rely on the clinical skills and inclination to trust the technical diagnostic results more than our clinical judgment. Disc prolapse, I admit that there is a considerable evidence on the clinical effectiveness of the discectomy for the carefully selected patient. The stress I'm putting on the carefully selected patients, because this is the sixth or seventh method of the treatment. Initially, you do the conservative treatment, and this is the selected patient with the cause of disc protrusion, which fail to resolve the conservative treatment. And understanding of the resolution of the sciatica and back pain is important. Natural recovery rates of the low back pain in the literature, it says that 80 to 90% attacks recover within 6 weeks, irrespective of the intervention. Whether you go for the surgery or if you go for the conservative treatment, it gets settled in 6 to 8 weeks. And 90% of the patient will have stopped the consulting the GP for the symptoms within 3 months. Surgical intervention versus conservative management for disc herniation. Faster recovery in the surgical intervention, but 90% of the patient treated non-operatively make the similar recovery within 2 years. Sciatica biological management. Sciatica can be managed by medication alone. Days are ahead when the surgery will only be indicated for the cauda equina lesion. And selection of the case is important to avoid the adverse effect. Because if the patient doesn't need a surgery, it can be treated with the medication, with the physiotherapy, with the injection, other methods which I'll come in this presentation now. So if you go directly for the surgery, that may have the adverse effect. Pain and anatomic structures. This is important slide to understand that low back pain, that is outer annulus, these are the 4 structures from which we get the low back pain. Outer annulus fibrosus, anterior epidural tissues when inflamed, and occasionally the facet joints and the vertebral enclaves. So we get the back pain from low back pain from these structures. And buttock pain we get from the annulus and compressed nerve root simultaneously. Whereas sciatica, compressed, stretched, or inflamed nerve. So these are 3 things. Either it's compressed, or it is stretched, or it is inflamed. Then we get the sciatica. And early patches of sciatica like knee, heel pain is inflamed nerve. 8 ways of treatment. So there are the 8 ways of treatment to address the low back pain and sciatica. First, as I said before, do nothing. It will settle in a couple of days or maybe in weeks, but you don't need any treatment at all. I'll come in the later on to elaborate this. Second is medicine. Third is physical therapy. Fourth is spinal injection. Fifth is minimally invasive spinal surgery. Sixth is microdiscectomy. Seventh is laminectomy and discectomy. And 8th is spinal fusion. If you see patient around you, mostly patient, they come under this 7th treatment, laminectomy and discectomy. Because as I said earlier in the presentation, that if you have a hammer in the hand, do nothing. Just need assurance to the patient that it will get better on its own and continue to normal activities. No need of rest, because rest is death and moment is life. If you do the rest, your muscle will get more weak and more wasted. So rest is not recommended for the back pain. If you can't move, that is not rest, that is disability. Then we go on the second and third treatment. But doing the rest just in a sake that I'll do the rest and my back pain will get better, it is not true. If you move, it will get better. Pain hurts, but it's not harmful. For the muscle, it say use it or lose it. If you use the muscle, it will develop. If you don't use it, it will get wasted. Second is medication. And medication also, do not start from the day one. If you, in a couple of days, 2-3 days, if you feel the pain is not settling down, or if pain is more, you can take straight away the painkiller. But if you feel the pain is not much and you can move around, to try the first method. And if you feel that it's a pain is not getting better, or 2-3 days gone and pain is still there, then you can take the medication like paracetamol, muscle relaxant, non-steroidal anti-inflammatory drugs, and lacosamide or gabapentin. These doctors can recommend you. This is when the pain is not only in the back, but when going down the legs, then we can add this also. Physical therapy. Physical therapy, there are so many modalities in the physical therapy, but main thing is the manual manipulation of the joints and addressing the trigger points. Mostly the patient prefer these machines, that shortwave diathermy and ultrasonic and mega infrared and all these things. But basically, the treatment which gives benefit to the patient is to release the trigger points. Injection therapy. People think that injection is dangerous, but no, it's not. It is, you can give the injection in the facet joint, steroids, or with the local anesthesia. And nerve root injection, there are 4 types of injection you can use. This facet joint injection, if you see on the X-ray or CT scan or MRI that there's a degeneration in the facet joint, you can give that. For the nerve root injection, if not responding to the conservative treatment,
समझ नहीं आ रही
क्या समझ नहीं आ रही?
From where you are not from where you are missing, can you
nerve root
I think it's
injection.
the volume.
are
उर्दू
you
बोली समझ नहीं आ रही उर्दू बोले
अच्छा उर्दू बोले अच्छा
are you not hearing properly?
Okay. No, he say that it's not in Urdu. That's what he's saying. That is the presentation is not in Urdu, so that's why he is not able to understand. So
क्या मैम कह रहे हैं उर्दू बोले
अच्छा. So these 4 injections, that facet joint injection, nerve root injection, epidural injection, and intradiscal injection. Now in intradiscal injection, now they also putting the ozone also. Ozone and stem cell therapy. I'll come later on this, but this is the 4th way of the treatment. Then acupuncture also, I have put in the injection as it's needles and still used in the Islamabad and other countries. Minimally invasive spinal surgery. This is me here. This was long ago in Innsbruck doing the minimally invasive spinal surgery, and the advantages of the minimal invasive spinal surgery is that it is the patient is awake.
प्लीज इंग्लिश नो उर्दू
Awake and Mulazim, can you please stop his speaker, please, microphone, please. Awake and aware state surgery with the precise targeting of the pain generators. So patient is awake. The difference between the minimal invasive spinal surgery and the conventional surgery is that the patient is awake and you can communicate with the patient that. And when the patient touches, the surgeon touches the nerve and the pain results, we can ask the patient that, is it the same pain which you feeling? He say yes or no. Then we touch another disc, so to find out the exact location of the pain generation, then we address that. Similarly, in the here in many hospitals, they do under general anesthesia, which is wrong. It should be under awake and aware state that you can communicate with the patient to locate where the pain is coming from. And it is reduced surgical, even we don't stitch the wound, it's because it's just like a needle and a small cannula. Increased effectiveness at the target and increased interaction during the surgery with the patient, and reduced cost and mobility. This is the method that you can go with a needle, and then you can put the trocar, the cannula, and so you can see easily that it is very, very minimally invasive, and it is there, even no stitch is needed.
Hello, assalamu alaikum.
Sixth method is micro discectomy. With the help of microscope and under general anesthesia, they do the discectomy. And seventh, decompression and laminectomy and discectomy. As I said before, that this should be tried when all other methods fails. Conservative and minimally invasive fails, then you can go for this method. Decompression and fixation is the last way of treatment, where you can fix the spine with the intervertebral disc also, or cage, or these are different methods you can fix the spine. But this is the last method. These are the references that I have collected from to prepare this disc.
Thank you so much.
So the take home message. The take home message left. Take home message is that nobody knows the exact cause of the back pain yet. The ways of treatment confirms lack of understanding. In addition to the various treatment modalities, yet another one, which is stem cell and ozone treatment, is emerging that have to be proven yet. It is already get practice in Islamabad and in Lahore and Karachi, but that also need to be proven. Still, there is a need to explore more in understanding and bring the standard ways of treatment and agreeable to all. Just suspecting the 2 Ds, that disc and degeneration, because up till now and in the last 50 years, we are suspecting these 2 Ds, disc and degeneration. So doing discectomy and fixation is not the solution. 90% patient can be treated non-surgically, and up to 97 or 93% MRI scan findings are false positive. So time will come when the surgery will only be for the cauda equina syndrome. If the conservative measures fails, the best option is minimal invasive spinal surgery. Thank you very much.